All right, I want to thank the organizers for having Joshua and myself here today. It's an exciting program, and we have a list of very engaging talks ahead of us. I have the privilege of introducing our first speaker, Professor David Ashley. Dr. Ashley actually is a well-decorated researcher. He hails from multiple departments of neurosurgery, pediatrics, medicine, and pathology at Duke University. He's also the director of the Preston Robert Tisch Brain Tumor Center at Duke, which is the largest brain tumor center in North America. We have the privilege of listening to one of his areas of expertise in immunotherapy in gliomas. But his research actually extends far more than that in the field of CNS tumors, as well as in his public health and psycho-oncology research. Because of his research, there has been multiple changes in the practice and care of both children and adults with brain tumors. So without further ado, let's listen to Dr. David Ashley for his first talk in this section.
So thanks for the very kind introduction, Melissa and Joshua. It's a privilege to be presenting. I wish I could be there in person clearly, but it's great that we can communicate like this. And appreciate the fact it's a little earlier because it's very late at night over in North America. This is a change in tack from our last speakers and will be much more translational in its orientation, and I hope you enjoy some of these somewhat counterintuitive findings that we have in malignant glioma. Let's move forward. So for those in the audience, glioblastoma is the most malignant of brain tumors, highly invasive. It's phenotypically heterogeneous, very resistant to therapy. It's a big problem for those of us in the field. In the United States, 3.4 cases per 100,000 lives, so relatively rare, but morbid problem for people with 250 something cases of primary malignant brain tumors in the United States, slightly more common in males than females. And as I said, the glioblastoma is a grade 4 malignancy, very difficult to treat in middle-aged to elderly people, and a median survival only 17 to 20 months. Unfortunately, the standard of care for these tumours has really not progressed over the last 2 or 3 decades. Those of us in the field started using temozolomide both in the concurrent with radiation and adjuvant setting some time ago in conjunction with near complete at best surgical resection, and as I said, radiation. And you can see there the 5-year follow-up with a relatively dismal outcome for radiotherapy in particular, but some advantage to the drug temozolomide, which is a monofunctional alkylator chemotherapy. There's some prognostic factors that we can identify in this illness, including age, performance status, extent of resection versus biopsy. But overall, despite all those somewhat better prognostic factors, outcomes have traditionally been very poor. And the outlook for recurrent glioblastoma is even worse, with really 100% of patients passing away well within 18 months, and the vast majority passing away within 12 months from the diagnosis of recurrence of disease. So with that in mind, a number of immune-based therapies have been trialled over the past few decades, and I do believe we're starting to make progress with these strategies, and these include vaccines, monoclonal antibodies, oncolytic viruses that I'll talk about today, and other types of immunotherapies. And in simple terms, and I know Dr. Scher is giving a talk later that will elucidate some of these issues for you in general surgical oncology terms, but I think of cancer immunotherapy having 3 prerequisites. You need available targets and we'll talk a little bit about this. This includes the somatic mutations that can provide tumour antigens or specific antigens to the immune system that can be targeted in conjunction with expression of MHC molecules. You need an orchestrated and effective response. So, you know, the T cells and other effector cells have to get into the tumour, and the microenvironment has to be conducive to anti-tumour responses. And in addition to that, there can be some intrinsic tumour cell resistance, and this is a focus of our research at the moment, but I won't be speaking about this today. Maybe I can come back for another talk at some point. Oops, sorry, wrong way. So today we'll concentrate on the top two, which is the targets and thinking about an orchestrated and effective immune response. So this is, you know, fundamental data from Alexandrov that was published nearly a decade ago, looking at the rates of somatic mutations across a variety of different cancers. And what one can see is that those tumours that generally have a reasonable track record with immunotherapy, such as melanoma or colorectal cancer, tend to aggregate in the tumours that have the higher rate of somatic mutation and therefore more available targets, perhaps, whereas brain tumours tend to congregate down at the lower end of the scale and have relatively few somatic mutations per megabase, in the order of, you know, often between 1 and 2, and the situation is even worse when you consider some of the pediatric tumours, polycytic astrocytomas, medulloblastomas, for example. And there is a relationship when one thinks about adaptive immune responses, for example, that can be amplified by checkpoint inhibitors, and the presence of large numbers of somatic mutations within the tumour. So this was documented, you know, back in the early part of the last decade, where investigators started to use next generation sequencing and identify the numbers of somatic mutations, and could see that with checkpoint inhibition, that often the survival dichotomized according to the mutational burden. And this is data from melanoma. There's more to it than that, though, and there is an interplay between the tumour mutational burden, the number of somatic mutations, and the presence of an inflamed microenvironment. So having lots of T cells and switched on macrophages in the microenvironment, which will predict response. And in fact, whilst these two things have an interplay, they are independent variables for response. So if a tumour has a large somatic mutational burden plus an inflamed tumour microenvironment, it's much more likely to respond to checkpoint inhibition or immunotherapy, adaptive immunotherapy. From the same paper or same observations back in 2013, you can characterize different types of tumours according to tumour mutational burden and gene expression profiling that identifies this inflamed microenvironment. And unfortunately, if you look right down to the bottom of that scale, glioblastoma is a tumour that generally has neither. It has neither a high tumour mutational burden or an inflamed environment. There are rare cases that occur in glioblastoma where there is a high tumour mutational burden, and there are patients who have a high mutational burden, and I'm going to come back to this, after they are insulted by temozolomide, and the alkylator therapy induces hypermutation in a number of patients' tumours at recurrence. In those cases, interestingly enough, even the presence of a high mutational burden does not portend for a good adaptive immune response, and checkpoint inhibition is really not very effective in patients with these tumours that have high mutational burden, because they tend to have cold or low responding tumour microenvironments. In fact, this is a paper from Keith Liggon's group up at Harvard, and in fact there was some suggestion that the patients with a high mutational burden actually did poorly, more poorly, with checkpoint inhibition in terms of progression-free and overall survival. So we started looking at this in relation to some work we'd done in the oncolytic viral treatment paradigm, and we were using the polio virus, and we discovered this very counterintuitive observation that demonstrated that very low mutational burden in glioblastomas at recurrence were a feature of inflammation and made these cancers responsive to immunotherapy. And I hope to show you some of that now and convince you that that's the case. So what we think we've demonstrated is that there's a subset of recurrent glioblastoma patients that do respond to both virotherapy, and I'll speak about that, and checkpoint blockade, so anti-PD-1 therapy, and that actually I've already touched on high tumor mutational burden is associated with resistance to these therapies, and hypermutant gliomas with mismatch repair, which I touched on, are also less responsive, but that the patients with the very lowest tumor mutational burden seem to be the responders. So it's quite counterintuitive to other tumor types. So a couple of years ago, we published this paper looking at recurrent glioblastoma that we treated with convection-enhanced delivery infusion of recombinant poliovirus and oncolytic virus. And what we were able to show is that there was a subset of patients, somewhere in the order of a quarter of patients, who responded to this, this virus infusion with very long stability of disease. And this is in the recurrent brain tumor setting. So the recurrent glioblastoma patients had a very long tail of survival compared to matched controls. And we took this group of patients and we were attempting to identify biomarkers of response through genomic analysis of DNA and RNA. This figure shows some of the next generation sequencing that we'd done. And what we noticed was that even though there was the usual range of suspects of mutations that you can see, EGFR, TP53, ATRX, for example, that there was really no clear pattern of particular mutations associated with response to the virus. But we did see this counterintuitive observation where, if you look at the lower parts of the panel, that the patients with the very longest survival seem to have the very lowest number of somatic mutations. And when we took that data and we looked at it in a different way, we were able to see that the patients with a very low tumor mutational burden of 1 or less per megabase of non-synonymous variants tended to survive much longer after the poliovirus infusion than the patients with the higher tumor mutational burden that tended to cluster and unfortunately pass away earlier, which was counterintuitive, as I said, to the other tumor types where higher tumor mutational burden tends to be associated with better response to immunotherapy. And here's some of that same data plotted as Kaplan-Meier plots. This was also true for time to recurrence on MRI scan. You can see there in panel B. And then we went to other data sets and we started to look at, so that was data related to the poliovirus, but we looked at other data sets and we saw a similar trend that patients who had a very low tumor mutational burden, as defined as less than the median in any cohort, tended to have a better survival after recurrence if they were treated with checkpoint inhibitors as well, anti-PD-1 in this case, in 2 separate cohorts. And this was not true of patients who were not treated with immunotherapy. And the lower panels represent TCGA or another consortium that we're part of that looked at that just looked at patients at the time of recurrence, but not those patients treated with immunotherapy. And you can see no significant difference in outcome. So what this is telling us is that this very low tumor mutational burden is a feature of recurrent glioblastomas that are responsive and it's a predictive biomarker, but it's not prognostic. So it actually predicts a response to immunotherapy. We think this is in part related to standard of care, and the reason we think that is that this the presence of alkylator-based mutations from temozolomide increase with the increasing tumor mutational burden, and the patients with the very lowest tumor mutational burden tend to have less alkylator-associated marks. So there is a relationship between temozolomide-induced mutations and the overall survival of patients. The lower the absence of temozolomide mutations tends to be associated with a better response to immunotherapy. We excluded the very hypermutant cases, and it makes no difference to the outcome if you do exclude those patients. And indeed, if we control for a variety of different confounders and other important prognostic factors such as MGMT methylation, IDH mutation, presence or absence of steroids or PTEN, there doesn't seem to be a difference. The one thing that did seem to make a slight difference was the presence or absence of a P53 mutation, and we're still working through that data. I'll just wind up pretty quickly. We were interested in what is the relationship between this low tumor mutational burden in this setting and the presence of an inflamed gene expression profile or a microenvironment that's conducive to response to immunotherapy. And indeed, you can see the top panel there is from newly diagnosed patients before they received any standard of care treatment, temozolomide or radiation, and there really is no inflamed signal. That there just is a fairly cold microenvironment. So these tumours are cold when they're first diagnosed, but after the tumours are treated with standard of care treatment, they tend to dichotomize according to the tumour mutational burden. And in the lower panel, you can see that the patients with the lower tumour mutational burden seem to have an inflamed tumour microenvironment, whereas the patients in the higher median tumour mutational burden tend to continue to have a cold microenvironment. We think this explains why they may be responding to the immunotherapy. And in fact, there's a busy slide, but if I just draw your attention to panel F, what it tells us by looking at matched patient samples. So this is a group of patients where we were able to identify a biopsy at diagnosis and then a tumor biopsy at recurrence. And what we see is those patients with a low tumor mutational burden, the actual mutational burden often becomes lower at the time of recurrence and is more likely to be inflamed. So the change is that the microenvironment becomes more inflamed at recurrence, and the tumor mutational burden drops in the lower tumor mutational burden patients from diagnosis, whereas those patients with a high tumor mutational burden at diagnosis, when they're newly diagnosed, tend to maintain a cold microenvironment and don't respond to immunotherapy. And again, just some correlative data, we think that this is related to immunoediting, and that the inflamed microenvironment we think is having an interplay by clipping off or removing clones that have these non-synonymous mutations. So we think this is interesting. We think it may apply to some other cancers, and we're starting to move our investigation in that regard. For example, pancreatic cancer may be one, triple negative breast cancer may be another where these features may apply. And I think we need to do work in that regard. But to summarize this data, we think there's several immunotherapies that will have activity in the recurrent glioblastoma setting, and there is a benefit in therefore in 10, maybe 20% of patients that can be identified through very low tumor mutational burden, and which is a prognostic factor, which is rather, that's a typographical error, sorry, the predictive for immune therapy response. The TMB is inversely correlated with this inflamed microenvironment, and that there is evidence of immunoediting. And where we're going with this is we've just reproduced the phase 2 data on the oncolytic viral work, and we're applying the same analytics to that group of patients. And we've just put in an application to the National Cancer Institute to do a prospective evaluation of this paradigm by partitioning patients on the basis of their tumor mutational burden. So finally, I just need to acknowledge all our funders, National Cancer Institute, NINDS, you can see them there, PBTF, and a number of families that have made major philanthropic donations to the Brain Tumour Centre, and the key people involved that are there: Mike Brown, Matthias Gromeyer, Gao Zhang, Andrea Muscat, Alan Friedman, Anik Desjardins, and Jim Herndon. Our collaborators at Tempus, who did much of the sequencing that you see here, Jackson Labs, Robert Hark, and who helped us with some of the analytics, as did the New Jersey Institute and Joanne Fay at Columbia. And I will stop and happy to take any questions. Thank you.
Thank you very much, David. I really enjoyed the talk. I'm going to open up this time now. We've got a couple of minutes left to the floor for any questions, and please feel free to type in your questions for those the people online. But maybe I'll start off the session session with a couple of questions on my own. I find this incredibly interesting because I guess we've always known about the role of tumor mutation burden and its prediction of response to immunotherapy. Plus, we've always known about inflamed tumor microenvironment and its role, and we find that patients with an inflamed tumor microenvironment often tend to do more poorly. But I didn't see the correlation between these two separate categories until now, and the findings are quite interesting. I wonder if this is, number one, applicable to other tumor types, and if you've looked at it in other cancers apart from glioblastomas. The second question I have is there a utility for CPS? Because in a clinical setting, a lot of our oncologists would look at a CPS score to predict response to immunotherapy, although I guess even those with a very low CPS score sometimes are given immunotherapy anyways, if there aren't any other options. And the last question I have is, have you seen the response of patients with a high tumor mutation burden but an inflamed microenvironment, or a low mutation burden and a non-inflamed tumor microenvironment, and do their responses fall somewhere in between?
Right, so let me unpack that. Our group has not specifically looked at other tumours, but there are other groups that are starting to, and there's been some meta-analyses performed. And certainly I think I said triple negative breast cancer and pancreatic cancer look like tumours that may have a similar relationship to glioblastoma in terms of tumour mutational burden. And they're not tumours that conventionally respond to checkpoint or other immunotherapies. So it may be that there's some reason to believe that there's a group of patients within those cohorts that might respond similarly to glioblastoma. You'll have to tell me what CPS is, because I'm not familiar with that terminology, I don't think. You educate me.
I think the CPS is often used by oncologists, and it looks at the percentage of lymphocytes, macrophages divided by the viable number of tumor cells, something to that extent. And I guess it helps to predict kind of response with a high CPS. One would think, it looks at PD-L1 receptors as well. So PD-L1 receptors divided by the viable tumor cells. So I guess with a high score, you would expect that there is a plethora of PD-L1 receptors, and you expect a better response than those with a low score, but it's not exactly completely accurate, I guess.
Yeah. So PD-L1 is not predictive of response to checkpoint inhibitors in glioma. I can't speak with any certainty. I know that it is in lung cancer. I know that it is in melanoma, some subsets of melanoma, colorectal perhaps, but there is no relationship between immunotherapy response and PD-L1 expression in glioma, and it has been looked at reasonably extensively. I think your other question, then the final question, was around the relationship between hypermutant state and inflamed microenvironment. In malignant glioma, the hypermutant tumors just don't seem to have an inflamed microenvironment, so you don't see that. The only patients who do seem, in the newly diagnosed setting, the only patients who do seem to respond to checkpoint inhibitors are those with Lynch syndrome. So this is a germline mutation of one of the mismatch repair enzymes that is much more frequently observed in colorectal cancer. And we see a subset of those patients who develop glioblastoma. And those patients are often hypermutant at diagnosis and do seem to respond to checkpoint inhibition. As yet, to the best of my knowledge, no one has examined the tumor microenvironment in those patients in any detail. And certainly we've got it on our radar to do that, but we've not done it yet.
Yeah. Really nice talk, Prof. Ashley. I've got a question in relation to the tumor mutational burden. In many cancers, a high tumor mutation burden is actually associated with a more inflamed kind of tumor microenvironment due to the increased antigen load that the tumors are presenting. I'm just curious to know why this is not the case in GBM, where instead you see the opposite.
Yeah, well, our own research suggests that there's an intimate link between innate immune, and it's another focus for us, between innate immune systems and adaptive immune systems. I actually am not sure that the mutational burden or the presence of neoantigens in the absence of an active innate immune system will lead to an inflamed microenvironment. One of the things about the brain is that it's a site of people used to term it immune privilege, but we call it immune difference, really. And there's an absence of a number of the toll-like receptors in innate immune system, such that it's very difficult to generate an immune response in the brain. And we think this is carried into brain tumors. So fundamentally, the brain creates an environment that just is agnostic to the presence of all those mutations, that it doesn't care. In fact, if you look at work by Paul Michel and Rolver Haak, human brain tumors have the largest number of extra chromosomal copy number abnormalities and circular DNA. And by rights, the presence of all that abnormal DNA should induce an immune response, but it just doesn't. And we think that's because of the brain microenvironment rather than the tumor microenvironment, if that makes sense.
Cool. That's really fascinating. Could I ask a bit about the polioviruses in your study as well? How do these viruses work? Are they genetically modified, or
so we modified the poliovirus. We took out the neuropathic components and replaced it with the rhinovirus. So it's a recombinant, heavily modified poliovirus that it enters the cell using the same receptor as the wild type poliovirus, but it's non-neuropathic. So it has all of the inflammatory components of the enterovirus, the poliovirus, but none of the nasty pieces that cause the paralysis. Or the neuroinflammation, or I shouldn't know, the neuropathic effects, the neuronal cell death. So it works actually by causing, we've published several papers on this now, the action of the virus is not primarily on the tumor cells, but actually on the microenvironment. What it does is it infects the microglia and the macrophages in the microenvironment and causes a change in their performance, and so they're much more likely to attract an immune response.
I see. Thank you, Prof.
Yes, there's questions, Jimmy So. Yeah, thanks, David, for this talk. And I'm just follow on Josh's topic on the immunoediting. Just curious as how your modified poliovirus can have a specific response for a patient with a GBM, because I say that you mentioned that it's targeting on the tumor microenvironment like macrophage. Are they tumor specific, or you think it will be individual specific? And this is my questions on that.
Yeah, no. What we don't have in the humans as yet is longitudinal specimens that allow us to do the types of analyses we'd like to understand what's happening. But we do have a lot of data from animal models, from mice, and what happens is the poliovirus, when we inject it into the tumors, primarily largely infects the antigen presenting cells, so the activated dendritic cells, the microglia, and the macrophages. And it causes a very brisk interferon response from those cells that in turn causes attraction of T cell, initially actually neutrophils and other myeloid cells, and then eventually T cells. And we think that through that action, that the change in that tumor milieu is enough for the T cells to become alerted to the presence of the somatic mutations within the tumor microenvironment. And then you get, from that point, you get a tumor immunization effect. And in fact, if you deplete the T cells from the mice, you do abrogate the response of the poliovirus, of the tumor to the poliovirus. So when we look at the tumor, again, we can make the tumor cells completely resistant to the poliovirus by deleting the poliovirus receptor, and yet the tumor is still rejected. So we can make a mouse model where we know for a fact that poliovirus only gets into the microenvironment cells and not the tumor cells at all, and the efficacy is not impaired.
Thank you very much for that, David. If there are no other burning questions, I don't see any from the floor or online. I'd like to close this talk. Let's give our hand to David once again.
Pleasure. Thanks for having me.